Postpartum complications. Number 1. Cystitis. An infection of the bladder can occur in the postpartum period. The postpartum woman should be encouraged to consume adequate fluids and void frequently to avoid bladder distension. Number 2. Hematoma. Localized collection of blood in the tissue and can occur internally involving the vaginal sulcus or other organs. Vulvar hematomas are more common. Predisposing conditions include operative delivery with forceps and injury to a blood vessel. Hematoma can be life-threatening condition. Assessment. Number 1. Abnormal severe pain. Number 2. Pressure in the perineal area. Number 3. Sensitive bulging mass in the perineal area with discolored skin. Number 4. Inability to void. Number 5. Decreased hemoglobin and hematocrit levels. Number 6. Changes in vital signs indicating shock such as tachycardia and hypotension. Intervention. Monitor client for abnormal pain or perineal pressure, especially when forceps delivery has occurred. Number 2. Monitor vital signs and for signs of shock. Number 3. Place ice at the hematoma site. Number 4. Administer analgesics as prescribed. Number 5. Prepare for urinary catheterization if the client is unable to void. Number 6. Administer blood products as prescribed. Number 7. Monitor for signs of infection such as increased temperature, pulse rate, and white blood cell count. Number 8. Administer antibiotics as prescribed because infection is common after hematoma formation. Number 9. Prepare for incision and evacuation of hematoma if necessary. Number 3. Uterine atony. A poorly contracted uterus that does not adequately compress large open vessels at the placental site. This can result hemorrhage. Assessment. A soft uterus noted on palpation of the uterine fundus. Interventions. Number 1. Massage the uterus until firmed. Number 2. Empty the woman's bladder by voiding or catheterization if that is contributing to the uterine atony. Number 3. Notify the healthcare provider if intervention does not resolve the atonic, because this can be an indication of hemorrhage. Number 4. Hemorrhage and shock. Number 1. Bleeding of 500 ml or more after delivery. Number 2. Can occur early during the first 24 hours after delivery or later after the first 24 hours following delivery. Number 3. Causes and predisposing factors. Uterine atony, laceration of the cervix or vagina, hematoma development in the cervix, perineum or labia, retained placental fragments. Predisposing factors: previous history of postpartum hemorrhage, placenta previa, abruptio placenta, overdistension of the uterus, polyhydramnios, multiple gestation, large neonate, infection, multiparity, dystocia, or labor that is prolonged. Operative delivery. Assessment. Number 1. Persistent significant bleeding, perineal pad is soaked within 15 minutes. Number 2. Restlessness, increased pulse rate, decrease in blood pressure, cool and clammy skin, ashen or grayish color. Number 3. Complaints of weakness, lightheadedness, or dyspnea. Intervention. Priority nursing actions. Hemorrhage and shock in the postpartum client. Number 1. Notify primary healthcare provider. Stay with the client and ask another nurse to contact the healthcare provider. Number 2. If uterus is atony, massage gently to cause it to contract. Number 3. Tilt the woman to his side or elevate the right hip. Elevate her legs to at least a 30-degree angle. Number 4. Administer oxygen by non-rebreather face mask or nasal cannula at least 8 to 10 liters per minute. Number 5. Monitor vital signs. Number 6. Administer uterotonic medications. Examples: oxytocin, prostaglandins as prescribed to uterine tone. Number 7. Provide additional or maintain existing intravenous infusion of lactated Ringer solution or normal saline solution to restore circulatory volume. Woman should have 2 patent IV lines. Insert second IV infusion using 16 to 18 gauge IV catheter. Number 8. Administer blood or blood products as prescribed. Number 9. Insert an indwelling catheter to monitor perfusion of kidneys. Number 10. Administer emergency medication as prescribed. Number 11. Prepare for possible surgery or other emergency treatments or procedures. Number 12. Record event, interventions instituted, and woman response to interventions. Note: in the postpartum client, if bleeding is excessive and signs of shock are evident, the nurse immediately contacts the healthcare provider because this is a life-threatening situation. The nurse never leaves a client who is unstable. Contact the healthcare provider. The nurse should quickly attempt to determine the cause of hemorrhage and if the client is experiencing uterine atony. The nurse should massage the uterus gently to cause it to contract. The nurse positions the client to assist in perfusion of body organs, implements prescription including oxygen administration, and monitors vital signs. Number 5. Infection. Any infection of the reproductive organs that occurs within 28 days of delivery or abortion. Assessment. Number 1. Fever. Number 2. Chills. Number 3. Anorexia. Number 4. Pelvic discomfort or pain. Number 5. Vaginal discharge that is malodorous. Normal vaginal discharge has a fleshy odor or an odor similar to a menstrual period. Number 6. Elevated white blood cell count. Note: a temperature of 100.4 Fahrenheit or 38 Celsius is normal during the first 24 hours postpartum because of dehydration. A temperature of 100.4 Fahrenheit or 38 Celsius or greater after 24 hours postpartum indicates infection. Interventions. Number 1. Monitor vital signs and temperature every 2 to 4 hours. Number 2. Make the client as comfortable as possible. Position the client to promote vaginal drainage. Number 3. Keep the client warm if chilled. Number 4. Isolate the newborn from the client only if the client can infect the newborn. Number 5. Provide a nutritious, high-calorie, high-protein diet. Number 6. Encourage fluids to 3,000 to 4,000 ml per day, if not contraindicated. Number 7. Encourage frequent voiding and monitor intake and output. Number 8. Monitor culture results if cultures were prescribed. Number 9. Administer antibiotics according to identified organisms as prescribed. Number 6. Mastitis. Number 1. Is inflammation of the breast as a result of infection. Number 2. Mastitis occurs primarily in breastfeeding mothers 2 to 3 weeks after delivery, but may occur at any time during lactation. Assessment. Number 1. Localized heat and swelling. Number 2. Pain, tender axillary lymph nodes. Number 3. Elevated temperature. Number 4. Complaints of flu-like symptoms. Interventions. Teach the client in good hand washing and breast hygiene. Number 2, promote comfort. Number 3, apply hot and cold compress to the site. Number 4, maintain lactation in breastfeeding mothers. Number 5, encourage manual expression of breast milk or use a breast pump every 4 hours. Number 6, encourage the client to support the breast by wearing a supportive bra. Avoid wearing underwire bra. Number 7, administer analgesics as prescribed. Number 8, administer antibiotics as prescribed. Number 7, pulmonary embolism. Passage of a thrombus often originating in a uterine or other pelvic vein into the lungs, where it disrupts the circulation of the blood. Assessment. Number 1, sudden dyspnea and chest pain. Number 2, tachypnea and tachycardia. Number 3, cough and lung crackles. Number 4, hemoptysis. Number 5, feeling of impending doom. Interventions. Number 1, administer oxygen. Number 2, position the client with the head of the bed elevated. Number 3, monitor vital signs frequently, especially respiratory rate and heart rate and breath sounds. Number 4, monitor for signs of respiratory distress and for signs of increasing hypoxemia. Number 5, administer IV fluids as prescribed. Number 6, administer anticoagulants as prescribed. Number 7, prepare to assist the healthcare provider to administer the medication to dissolve the clot if prescribed. Number 8, subinvolution. Incomplete involution or failure of the uterus to return to its normal size and condition. Assessment. Number 1, uterine pain on palpation. Number 2, uterus larger than expected. Number 3, more than normal vaginal bleeding. Interventions. Number 1, assess vital signs. Number 2, assess uterus and fundus. Number 3, monitor for uterine pain and vaginal bleeding. Number 4, elevate legs to promote venous return. Number 5, encourage frequent voiding. Number 6, monitor hemoglobin and hematocrit. Number 7, prepare to administer methylar gonovine mylate, which provides sustained contraction of the uterus as prescribed. Number 9, thrombophlebitis. Number 1, a clot forms in a vessel wall as a result of inflammation of the vessel wall. Number 2, a partial obstruction of the vessel can occur. Number 3, increased blood clotting factors in the postpartum period place the client at risk. Number 4, early ambulation in the post-operative period after cesarean section is a preventive measure. Types. 1, superficial thrombophlebitis. 2, femoral thrombophlebitis. 3, pelvic thrombophlebitis. Assessment of types of thrombophlebitis. Superficial, palpable thrombus that feels bumpy and hard. Tenderness and pain in affected lower extremity. Warm and pinkish red color over the thrombus area. Femoral thrombophlebitis. Malaise, chills and fever, diminished peripheral pulses, shiny white skin over affected area, pain, stiffness and swelling of affected leg. Pelvic thrombophlebitis. Severe chills, dramatic body temperature changes. Pulmonary embolism may be the first sign. Intervention 1. Specific therapies may depend on location and thrombophlebitis. 2. Assess the lower extremities for edema, tenderness, varices, and increased skin temperature. 3. Maintain bed rest. 4.
Elevate the affected leg. 5. Apply a bed cradle and keep bedclothes off the affected leg. 6. Never massage the leg. Number 7. Monitor for manifestations of pulmonary embolism. Number 8. Apply hot packs. Number 9. Apply compression stockings if prescribed. Number 10. Administer analgesics and antibiotics as prescribed. Number 11. Heparin sodium intravenously may be prescribed for femoral or pelvic thrombophlebitis to prevent further thrombus formation. Client education for thrombophlebitis. Never massage the leg. Avoid crossing the legs. Avoid prolonged sitting. Avoid constrictive clothing. Avoid pressure behind the knees. Know how to apply elastic stockings if prescribed. Understand the importance of compliance with anticoagulant therapy if prescribed. Understand the importance of the follow-up with the healthcare provider. Number 10. Perinatal loss. Number 1. Associated with miscarriage, neonatal death, stillbirth, and therapeutic abortion. Number 2. Loss and grief also may occur with the birth of a preterm baby, a newborn with complications of birth, or a newborn with congenital anomalies. It also may occur in a client who is giving up a child for adoption. Note: not all interventions are appropriate for every woman and her family who has experienced perinatal loss. It is crucial to consider religious, spiritual, and cultural healthcare practices and beliefs when planning care for a woman and family who have experienced perinatal loss. 1. Communicate therapeutically and actively listen, providing parents time to grieve. 2. Notify the hospital chaplain or other religious person. 3. Discuss with the parents options such as seeing, holding, bathing, or dressing with a deceased infant, visitation of other family members of friends, religious, spiritual, or cultural rituals, and funeral arrangements. 4. Prepare a special memories box with keepsakes such as footprints, handprints, locks of hair, and pictures if appropriate. Number 5. Admit the mother to a private room. If possible, mark the door to a room with a special card or per agency procedure and maintaining confidentiality that denotes to hospital staff that this family experienced a loss. Thanks for watching. Please like, share, and subscribe.